Okay, so we're going to change gears now. So very excited by all of our talks today, but especially to be able to introduce Victoria Atkinson. You may know that Queensland is the melanoma capital of the world, sadly. We have the world's highest incidence rates of melanoma. We have had a very high mortality from melanoma. And I study melanoma as a researcher. And for most of my career, for people with metastatic melanoma that's spread, it's been a pretty bad prognosis, and we really didn't have much to offer patients really when they had disseminated disease. And so it has been an extraordinary era in the last 10 or 15 years with a whole range of new therapies for melanomas and for other cancers using the body's immune system. And right at the forefront of a lot of this work is our next speaker, Professor Victoria Atkinson. It's a delight to welcome her to the stage. Victoria is one of our most senior medical oncologists in Queensland. She's on the stage around the world presenting the work of trials done here in Queensland. And so please join with me in welcoming Victoria to the stage.
This is actually a really tricky talk to give. So I give lots of talks. This is my fourth in 3 weeks. But most of my talks tend to be the same theme. I talk about melanoma and I talk about melanoma. And so being asked to speak as live as a clinician-scientist was a little bit trickier because I was like, what does that talk look like? And so I asked what they would be wanting, and they said, well, describe how you got where you were. So why did I choose to become a doctor? So I chose it back in 1992 because of job security. So back when I started, there was a 100% employment for doctors once you finished medical school, and job security was important. I had quite a bit of experience with the healthcare system growing up, and I had an interest in science. So what did it look like? So I finished in 1998. I went to a state school in Queensland, in Logan. So coming to university was quite different. I did my internship here at the Royal Brisbane. Went over to the Princess Alexandra for 1 year, and I completed my training as a medical oncologist in 2006. In 2006, the medical oncology world was very different. So there wasn't a lot of treatment, as David alluded to, for a vast variety of cancers. We were reasonably good at breast cancer, but the rest of the cancers were actually pretty dire. And I had a choice of where I could go. So there were a couple of different opportunities for me. But basically, I chose to work at the Princess Alexandra Hospital. And the way I chose where I went to work as a medical oncologist was actually based on my colleagues in the department. So I didn't go there because I thought it was going to be a centre of excellence or anything exciting. I just went, I've worked with these people before. These are nice people, because remember, the department that you end up in as an oncologist or a doctor is the people you're going to be seeing every day for many years. And it was a nice group of people, so I went, I'm going to go and work at PA. I mean, I had to cross the river because I'd always been on this side of the river. And you know, that river in Brisbane is very hard to cross, but I did go to the south side. So oncology as a specialty has changed really, really rapidly. First started in 1972, and when I started as a medical oncologist, Damien Thompson was the director at PA, and he was actually the first medical oncologist in Queensland. Oncology has always lent itself to clinician-scientists. So over and above all the other specialties, I think it is very, very data-driven. Most of what we do is based on clinical trials, and most of what is funded in Australia and around the world is driven on the data that supports this as a treatment option. So it's very, very protocol specific. And when I started as a medical oncologist, it was literally just at the start of the revolution of targeted therapy and immunotherapy. So when I started in 2007, everyone did all tumours, so there was no tumour specificity, which there is now, particularly in the big cities. There was one chemo for prostate cancer, which didn't really do anything. We had 2 drugs for lung cancer. We didn't treat gallbladder cancer, we didn't treat kidney cancer because there was no treatments for it. Pancreas cancer was dismal. Melanoma, the treatment for melanoma had never been shown to make anybody live any longer. Our clinics were tiny because people would see them twice and then they'd die. There was a few treatments for breast cancer and a couple of treatments for colorectal cancer. So it really was, I was in the right place at the right time. So how did I get into melanoma? So people ask, how did that happen? So when I started as a medical oncologist, as David alluded to, the 5-year survival for metastatic melanoma was 9%. Very few medical oncologists wanted to specialise in melanoma because it was seen as a disease which, for 30 years of clinical research, nothing had ever changed, and there weren't any treatments. There was a real clinical need for research, and there had been 30 years of clinical trials. It wasn't because people weren't trying, it's just that things didn't work. And in 2007, I started with one of my colleagues, because we both started as medical oncologists at the same time, and I was given the choice of you can do sarcoma or you can do melanoma. And the reason that I became a melanoma oncologist is that the sarcoma doctors were all male and possibly not desperately welcoming to a female medical oncologist. So there was actually still quite a lot of sexism in the orthopedic sarcoma specialty, whereas the melanoma surgeons were very, very welcoming, really nice guys to work with. And so the reason I chose melanoma was literally because I didn't want to go and work with the orthopedic guys, because, you know, they'd only talk to you if there was no man in the room. And luckily, the amount of sexism has actually significantly reduced in medicine. So even when I started as an intern going through my medical training, there was a lot of sexism. So I can remember someone telling me that they had to train 2 women for every man because women only work part-time. Or that it was pointless training women because they're just going to go off and get married. So that was one of the general physicians that I interned for. So it has actually improved a lot, and over the past 10 years, a lot of the old guard of older people with potentially some less progressive thought processes have retired, and so it's actually become a lot more, what's the word for it? A lot more equal and fair, and there's a lot less sexism in medicine. I'm not going to lie, there's still the lady ceiling. So you don't see women as heads of department, you don't see women on some of the really big academic things. This has gotten a lot better, particularly in melanoma. So Georgina Long has really pushed melanoma forward and has got a very heavy presence, but there still is that ceiling for women. I chose melanoma because patients were very keen on trials. So patients would come in and they're desperate for something to work, and so they were lovely. But now it's this constantly evolving new treatments, and it is actually on the forefront of all scientific breakthroughs, because when we look at the new treatments for the majority of cancers, they are trialled in melanoma first. Part of that is because melanoma very much has an immunological basis behind some of its treatments. And so that they try it in melanoma, and if it works in melanoma, then it goes out to the other tumours. So now everyone's a lot more interested in doing melanoma. And when we get our young medical oncology trainees coming through, they're always like, oh, I want to do lung cancer and melanoma, which are the interesting places to be. Just to give you a feeling of the timeline, where my timeline and the melanoma timeline intersected. So you can see melanoma was actually first described in 1804, Breslow thickness in 1970. Dacarbazine, which we were still using in the clinic when I started as a medical oncologist, was approved for use in 1975. It actually didn't give a survival benefit, it was just approved for use. IL-2 was approved for use in 1992. IL-2 has never come to Australia outside of clinical trials because of its toxicities. You can see that the NRAS mutation and the BRAF mutations were described. And I started treating melanoma patients right before all of these other therapies came along. So I had the good fortune of being in clinic when BRAF inhibitors came to clinic, and that was impressive to see. I mean, so we're talking about tablets that you can give people that will make their melanomas literally reduced in front of your eyes. They take about 5 days to kick in. It is an easy come, easy go, and that resistance is mostly inevitable. Then we start a combination. But where things really changed is down the bottom here with the immune therapies. So we can see that CTLA monotherapy, that's an immunotherapy that we use for melanoma. It was the first therapy to ever make anyone live longer for melanoma, and it cures people. It's in metastatic disease. We have been curing metastatic melanoma for some years. a very small proportion of people, the CTLA4, but it cures people. Single agent PD-1 was first described in 2012, but the trials in advanced disease were published in 2014 and 15. This really cures people. So these medications, they don't cure everyone, but these are medications I can give people with brain metastases. And we have patients with 50 brain metastases. We can give them combination immune therapy and they finish their treatment and they're cured. And that's something that I would have never dreamed when I started my career, that we would ever be able to say that we can cure people with metastatic solid tumours. So certainly we can do that for melanoma. So the outcomes for melanoma have gone from 9% at 5 years to, if you're BRAF wild type, which is a particular mutation that we have, 52% at 5 years. And if you're BRAF mutant, we've got a 60% 5-year overall survival. And the reason as medical oncologists we concentrate on 5 years is because that's when we go, if your disease hasn't come back by then, you're probably cured. So we've had these drugs in Brisbane since 2013. I started stopping people's treatment in 2015. I started discharging people from my clinic in 2020. So I've been actively discharging people with metastatic melanoma for about 4 years now. And it's one of those things that, as an oncologist, there's really not words to describe it when you see someone with terribly advanced disease and you know that if this drug doesn't work, they've got 3 to 6 months to live. And you'd have that first scan and you can see a complete metabolic response in imaging and you can go to that person. It is exceptionally likely that you will be cured from here on in, because we know that that PET-CT complete metabolic response really does correlate with outcomes. I've had people who've gone on to have children after having their metastatic melanoma treatment. So some of our ladies have gone on to have babies. And their patients that we cure are always obviously forever grateful. There's no getting around, a large proportion still die, but we make them live longer or we give them better quality of life. So there's no getting around. It's a very interesting time to have lived through as a medical oncologist. So this is how I got into research. I was in the right place at the right time with the right people. That's actually a really tricky place to put yourself in. I was in the right place because of the timelines. Melanoma clinic, the people who were running melanoma clinic were stepping back, and so someone needed to come in and take over all the trials, because you're not going to walk into any particular unit and people are going to go, here's some trials I want you to be principal investigator of, take them off me. That doesn't happen. And I was in the right place in that there was some restructuring of 2 clinical trial units that have been very important to my career at the right time. And so that's a really difficult thing to replicate, being in the right place at the right time. What do you need to do clinical research? Obviously you need to complete your medical degree. I think across the junior year, so I'm talking past your intern year, there's a focus on opportunities for research. Certainly when we have people come into our units, we do let them know that if they're interested, we're obviously happy to have them participate in audits or research. There is an increasing requirement for people to have some research on their CV, and that's just because of the vast expansion of medical students. And so obviously when coming to advanced training now, it's a lot more competitive. When I was trying to be a medical oncologist in 2003, there were 6 positions in Queensland, extra finger, and they took 2 new ones each year, and so it was a lot less competitive. Now we have across Queensland something like 20 odd places for training, but how many positions we have depends on how many people are leaving. So sometimes it can be really competitive and we have lots of people applying, and some years we will have few, but the requirements to be interested in research and do research is definitely increasing. And then you also need to work in an academic centre. So you need to work in a centre that has an interest in research, that supports research, and that is actually a very tricky thing. Clinical medicine is obviously what I do, so I'm in clinic every single day. The research is interwoven in my clinical day, and you need to balance your clinical responsibilities, particularly as a clinical oncologist, because I'm employed by Queensland Health not to do research. I'm employed to see patients and look after patients. So you need to balance your clinical responsibilities with your activities. You need effective communication skills to collaborate with your colleagues and write grants. So there's no getting around that investigator-initiated grants are hard work. And then when you get the grant, it's even harder work. So being CIA of an HMRC grant is more work than you could possibly conceive. So you get the kudos when you get the grant, and then it's actually much more work than you could ever possibly envision to actually run a grant. But, certainly leaning on your colleagues and collaborating will make that a little bit easier. What do I like about research? Because, I don't have to do research. I could just see patients. It's working within a team. So I have a really close-knit trial unit at PA. I have a really nice trial unit at Greenslopes. They're lovely people. They're collaborative. They're detail-orientated. And their primary goal is obviously to help patients get access to cutting-edge therapies long before things come commercially available. So when we're seeing things in phase 1, 2 or 3 trials, you've got to remember that before these drugs actually get into the clinic, those trials need to report. And on average in Australia, it takes between 12 to 24 months from a positive trial to something actually being funded by the PBS. And that's because the PBS in Australia, particularly for cancer medicines, is reasonably rigorous. They do like to see an overall survival benefit. And then it's all about the quality of life years and the cost effectiveness of it. So a lot of our delays to treatment is about the pharma companies and the Australian government coming to a decision on costing. So clinical trials allows patients to access therapies that they won't be able to get for years. So for example, TILs, exciting new things. So that's where we take a piece of tumour, it goes off to America, they infuse it with some cytokines, comes back, we give some chemotherapy, we give the lifileucel, which are T cells back, and then we give IL-2. That's actually going to start in Queensland. We've got our first patient getting TILs in 2 or 3 weeks' time. We won't be the first in Australia. The Western Australians beat us by about a week, and that's because our first patient was randomised to the control arm, so it actually wasn't fair. But this is, because when you randomise, you don't get to choose. But this is treatment that is going to change practice in Australia, and the ability to be able to offer patient treatments that cost $1.4 million to pay for, that's the quote for TILs in America, is very exciting. What does it look like in my day-to-day life? Research is unpaid. So as a clinician-scientist, no one pays me for doing anything. There's no getting around that Queensland Health has within its auspices that research is important, yeah. But actually the Queensland Health doesn't value research. So there's no support from Queensland Health. They're just like, great, if you could do it, but as long as we don't have to actually do anything to support you or help you do it. So it's done after completing your service requirements. It involves multiple team members. So you've got pharmacists that you need to be friendly with and have them doing all the things that you want to do, including giving the right drug to the right patient at the right time, nursing staff, and the trials unit. And research can either be investigator-initiated, so that means I think of an idea, I write a grant, I write a protocol, this is what we're going to do, or they can be pharma-supported. And there's pros and cons to both. There is no getting around that the majority of research is pharma-supported because it's not just Queensland. Australia as a whole doesn't fund research particularly well. Queensland's just worse than New South Wales or Victoria. So what's my research output look like? So if you had said to me when I was here as a medical student, because I was here on the Hurston campus from 1996 to 98, that I would have 9 New England Journal Medicine papers with my name on, I would have laughed at you. As you can see, I have been very lucky to be in the right place at the right time, and I actually have quite a good CV for a Queenslander. And so that means that when grant times come, I get lots of invitations for people to say, "Well, you come and be on my grant," because this type of CV actually rates quite highly for grant applications. But basically, this is because I had been involved in trials since 2010, because I was in the right place at the right time, and it was actually a lot of it to do with luck. And as I said, I've been curing and discharging patients since 2020. There have been patients that, as I said, we haven't cured. And, you know, for the most part, I do remember all the people who I've met along the way who, unfortunately, we haven't helped. Should you get a mentor? Mentors are a tricky thing. Do they help? I actually don't know if I ever had a mentor. So certainly, two of the senior medical oncologists were helpful in that they gave me the trials, but mentors would be helpful for providing guidance and support, and they can provide insights like this. Like, you know, when one of my junior colleagues says they're going to be CIA on the MRC grant, I'm like, excellent. Expect this to be really, really difficult, and just give them some advice. I think it's really important that you have a mentor who has similar values and goals as you, and someone who can offer feedback and support. So mentors, I think, are a thing that you could have, and particularly giving you the feedback would be very helpful. So what would my advice be for you guys? Find something that you enjoy. As a medical oncologist, the one thing that I know, because I see it every day in my work, is that life is incredibly fleeting. That we are not here for very long, and things can happen. That means that your time may be shorter or longer. So you've got to do something that you actually enjoy. You don't want to be waking up in the morning and going, "Oh, I have to go back into work." It's actually okay if you don't want to do research. So I see on some of the forums that I'm on, people are like, "Oh, I feel bad because I'm not doing research. I'm just doing my job and I'm looking after my kids and I'm looking after my family." It's okay if you don't want to do research. It's okay if you do. And it's okay if, as you say, it goes the squiggly lines, but there's no right way to do this. It's really about what's best for you within your circumstances at this particular time point for you. And being the smartest person in the room is actually not necessary. What you want is to look for people that you want to work with, that you want to collaborate with, that may have ideas that you value. So that would be my advice to you. And I put in a cat me. I'm not a cat person.
Victoria, that was absolutely fantastic. You can see why Victoria's also asked to speak all around the world. A terrific talk, and even though it's not your core topic,
Yes, very difficult.
You've nailed it.
Yeah.
Thank you. Questions for Victoria?
There's a lady over there.
Well, there's a couple here, so one here and then one at the front.
Okay, thank you. My name is Mimi. I'm from Indonesia. I was a GP and new researcher. I want to ask about the mentor. How to find mentor here, because I just moved here. I tried to send email, but there is no reply until now. My background is breast cancer, and I like to do clinical trials because 2 years my experience in Indonesia. Thank you.
Yeah, that's tricky. I think a mentor is actually a little bit happy if you actually have met the person, whether that be at a meeting. Obviously, there's breast cancer meetings or popping along to clinic, because we get lots of emails. And I'm sure David gets them as well, from random people saying, "Look, I'd like to come and work with you. Here's my PhD." And you can't tell whether this is spam or whether or not this is real. So I think sending emails is probably a little bit trickier. Certainly from my perspective, most of the people that I've mentored over the years have been trainees that I've worked with, that I've come into contact with via that way. I think it's possibly a little bit tricky to meet people via email because of, when you get 30 emails overnight and some of them say, "Dear doctor, I would like to." So I think possibly maybe trying to work an in-person introduction via whatever clinical method that you can do, because I'm certainly going to struggle to reply to an email from someone I actually don't personally know, or hasn't been recommended by someone.
I think a face-to-face meeting encounter in some way, in a clinical setting or a conference setting or a workshop setting.
It's a bit easier.
That's a lot easier, because then you can engage and you can work out if the person's on the same wavelength.
And it's not spam from
Yes.
from someone. I think that's another question.
say events like this.
Events like this, yeah.
Hey, Victoria. Just like to say thank you for taking the time to give us this speech. Just a bit about myself. I recently got a new investigator grant for heart transplant research, and I'd like to ask, what are the general pros and cons of grants, and what's the distinction between pharma support and investigator-initiated grants?
So congrats on getting a grant. Grants are very important. And grants are really important on your CV when you're looking to do things in the future. So they actually do look very good on an academic CV. Obviously, important to get that grant up and running and have it be a successful grant with a research outcome. The tricky thing in Australia is that investigator-initiated grants, for the most part, are not going to be the most groundbreaking research just because we have such a small population. So for the most part, even in Queensland, we're not going to be inventing the new PD-1. So I think probably one of the most recent things that has really come out of Queensland was the HPV vaccine, but that's probably the most groundbreaking thing that's come because we don't have the population and we don't have the infrastructure and support. So investigator-initiated grants often ask questions that are not commercially viable. So for example, I have a grant which is not interesting, it's not sexy, it's about looking at discontinuation versus continuing treatment and is there a different outcome. That's not going to make any top tier research, but it's an important question to answer, like do we need to continue treating people? So for the most part, investigator-initiated grants in Australia are smaller pieces of research, but also they can be equally important. Pharma research is quite different. So the thing about pharma research is it's usually well funded, and that's what pays for our trials units. So our trial unit staff is paid for by pharma because they pay X amount of dollars per patient that we enroll in a trial, and that helps support our staffing requirements. The pharma trials, for the most part, is where, particularly for oncology, all the groundbreaking stuff comes from. So all those PD-1 trials are pharma supported. They have the drugs, they have the pipeline. We give them the people and we give them the clinical support. So they tend to have a lot more interesting and valuable things for the patients, and they tend to be the things that are more likely to be published. So in our clinical trial units, we always have some investigator-initiated and some pharma, and we think that's important to have because the other thing the pharma trials do, is they make up for the cost of the investigator-initiated study. So when we have an investigator-initiated study, just for an example, like maybe we will get $5,000 per patient that's enrolled and completed in the study. That's not going to cover costs. That's not going to cover staffing costs. That's not going to cover the scans and all the various things that we need to do. And we obviously can't run at a loss because Queensland Health and we can't. So say when we get a standard phase 3 trial, we'll get like $30,000 for that patient. And the costs are probably not that. And so that little bit of extra money helps support our investigator-initiated grants. So most clinical trials groups have a cohort of investigator-initiated, low-paying but interesting academic question grants and trials running over here. And we have our pharma trials, which have got the new drugs and potentially exciting new therapies for patients, and that little bit of extra surplus money, because the money doesn't come to me and it just stays with the unit, helps pay for the investigator-initiated trials and for the costs of running the trial with the staffing. So I think they're both equally as important, and they look great on your CV when you get a grant, but possibly not. The likelihood that any investigator-initiated trial is going to lead to a new HPV vaccine is relatively low.
I might just add to that, it's probably in part as well discipline specific. So I'd say in public health where I work and in general practice, it's probably the majority are investigator-initiated grants. So investigators do the research that drug companies don't want to do or aren't interested in. So there's a sort of a yin and yang about these things. And a lot of the times, the basic research that ultimately leads to a new drug will be investigator-initiated in the universities and institutes, but it's the hard slog, and a lot of those things don't work. Most of them don't work. They don't cross the valley of death, but occasionally they do. They get put into a trial, and that's when pharma or industry will really pick it up, and bells and whistles, everything thrown at it. So they often form different functions in the ecosystem of research. They come in at different places.
But we need the pharma. So pharma aren't evil. We do need them because to take that drug and get it to market is going to be like $100 million.
Yep. And to prove it's safe and to make it work.
And so it's really, really expensive. And, you know, I've talked about all the trials that have been positive. In the last 5 years, we've had a number of molecules that looked really exciting, pharma took up, and they haven't worked. So that's included some things that really looked promising in the early studies, but in the big randomised phase 3 study, didn't do a thing. But that's why I like oncology medicine, is because it is so incredibly data-driven, and our protocols are data-driven. When we see patients, there's nuances about what we do, so that's why you don't need an AI bot, and medical oncologists are always going to be really important. But it is very, very much data-driven, and when I see a patient, I can say, this is the evidence for what I'm going to give you. How that applies to you is tricky, but there is good evidence behind what we do.
Now, we will stop for a break shortly. There's one last question there, if it's a short one.
Yeah, just a quick one. It's interesting you said you do a lot of the stuff in your own time.
Yep.
Are there actually any funding opportunities to have your time as a clinician, as a clinician scientist?
And I'll just repeat the question for the audience in case you didn't hear. The question is, Victoria, a lot of your research is funded in your own time. Are there any schemes or options to offset that and pay for your research time?
I don't think easily within Queensland Health. So Queensland Health, as you would all be potentially aware, runs at a huge loss. So we're deep in the red every single year, and all we ever hear about is how much in the red Queensland Health is in our hospitals. So I don't see any foreseeable Queensland Health funding research in any way, shape or form in the future.
They did offer those little fellowships for a while, for a competitive fellowship for clinician researchers. I don't think that's still being offered anymore.
So I think probably not a huge amount. I don't know. So I have to say I really don't think that there's any funding. It's really tricky. So Queensland Health likes to say it supports research, and you know they like to say that they love it, and they love it when you know the things come and it has Princess Alexandra Hospital attached to it in the byline. But they're literally, I would have to say, is I've never had any support from Queensland Health ever.
What about if people had a university appointment as well as a clinical appointment?
Yeah, but I've never seen that in practice as a clinician for oncology. So I know it does happen for some of the other specialties. So I know some of my surgical colleagues have a part-time university appointment. I've never seen that in oncology in Queensland. Doesn't mean it doesn't happen. It's just not something that's common.
Not commonplace.
Yeah, because you know we're like little worker bees and monkeys in the clinic, and that's what they want us to do. Is they want us to see patients. Despite what they say.
And get 9 New England Journal papers.
Yeah, because each one comes with a byline that says Princess Alexandra Hospital, Gallipoli Medical Research Foundation and University of Queensland. And that looks good for Queensland Health, but they just like that it happens.
Well, keep doing the work you do. Thank you everyone for attending the first session and for your questions. Let's have a break and we come back at 11:15. And thanks again to Victoria and to Paul.